now we will move on to our academic session. To introduce our today's speakers, I welcome our webinar coordinators, Dr. Sajish Ji and Dr. Rajesh MC. Dr. Sajish, please. Dr. Sajish is our past ISA Kerala State President. Dr. Rajesh MC is our ISA Kerala State Journal Editor. Dr. Sajish, please.
Yes, thank you, the dignitaries and our senior leaders and present national and state leaders. My job is to introduce the speaker, our Dr. J. Balavendra Subramaniam, for the first talk. As we all know, the Bala doesn't need any introduction, but he started his career from anesthesia from the Jibma, Chandigarh. From now he is in the Ganga for the last at least more than 20-25 years as an academic director and a senior consultant there. He holds many awards in academics and it's a clinical work. He is the man behind the IORA and GARC, and he's an excellent clinician and academician. And I had an opportunity to associate with him in all the workshops from at least for the last 17 years. We are working together in nationally and internationally there. And it's from the state level, ISA Kerala state chapter. It's our honor and pleasure to have Bala in a dual role as an inauguration of the prestigious our AnaesthesiaCONNECT program and to deliver a lecture on role of regional anesthesia and analgesia in current day practice. No other person can do better than him. So I am handing over to Bala Venkat. Over to Bala.
Good evening, everyone. At the outset, I would like to extend my very sincere thanks to the President of ISA Kerala State Branch, Dr. Binil Isaac Matthew, and Honorary Secretary, Dr. Vijesh Venugopal, and the entire leadership of ISA State Chapter, State Branch of Indian Society of Anesthesiologists for initiating this academic program, the AnaesthesiaCONNECT. And I'm sure the exchange of knowledge that would happen because of this would benefit a lot of colleagues across the state of Kerala. I bring to you greetings from the city of Coimbatore, symbolized by Adiyogi. And slide move on. I'm extremely happy that on behalf of the National Governing Council of Indian Society of Anesthesiologists, I wanted to thank all the members of ISA Kerala State for actively participating in several academic activities throughout the year. And I'm also happy to share that there have been several ISA initiatives across the country, including the College of Indian Society of Anesthesiologists, the academic wing of ISA, and the simulation-based learning through ISA module, in which the ISA National signed an MOU with 40 simulation centers across the country to do case scenarios which actually result in morbidity and mortality in several parts of the country. And we are extremely happy that we have signed MOU with several organizations across the world, including American Society of Anesthesia, European Society of Anesthesia and Intensive Care, American Society of Enhanced Recovery. And we also look forward for a large delegation from India to the World Congress of Anesthesia 2026 at Marrakesh, Morocco. And I would wanted to thank and congratulate the pioneering work taken by Kerala's branch members, especially Dr. Arun Krishna from Thrissur, in initiating this activity of taking an Indian delegation to the World Congress. I take this opportunity to welcome you all to the upcoming National Conference of Indian Society of Anesthesiologists at Raipur. The registrations are open. It promises to be an academic event of great relevance with over 24 international faculty participating in this from across the world, and excellent master classes and workshops, live workshops, which will mark this academic extravaganza at Raipur. So welcome you all to Raipur. And I also bring to you greetings as the Secretary of the World Federation of Society of Anesthesiologists, which is headquartered in London. And the value of our federation is to have universal access to safe anesthesia. And the mission is to unite and empower anesthesiologists around the world to improve patient care. And these are the priorities of the World Federation of Society of Anesthesiologists, which want to educate, collaborate, and advocate, I think, which is akin to ISA's principles and akin to ISA Kerala chapter, Kerala branch principles. So once more, I welcome you all to the World Congress of Anesthesia in Marrakesh, Morocco, starting on the 15th of April, 2026. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore, a 650-bedded tertiary care referral center for trauma orthopedics. And this is the center which gave me the opportunity to use ultrasound. And I think ultrasound has become an inherent part of our clinical work. And what's the role of regional anesthesia in the perioperative care is the topic that I would wanted to share with you in the next few minutes. Aristotle and Plato said, pain, like pleasure, is a passion of the soul. That's an emotion and not that of the senses. And yesteryears, it was believed that if somebody was having severe pain, it was because an evil spirit had entered the body, and they used to put burr holes, and they thought by releasing the spirit from inside, the pain will subside. Then came the pain relieving strategies like cocaine drops. But I wanted to quote, we have moved from here to a phenomenal accomplishment as an anesthesiologist. And this has been possible because of this particular statement, which I think we should make it ours. Charles Darwin said, it's not the strongest of the species that survive, not the most intelligent, but the one most responsive to change. And thanks to the anesthesiologists across this country who have changed for the good, and they've included ultrasound into their clinical practice, which has revolutionized the practice of perioperative care, both in terms of pain relief and in terms of point of care ultrasound. I would like to quote this statement, and we need to take a cue from our own nation, India. When we achieved independence, this is what we looked like. This was the heart of Mumbai. This is exactly what we looked like, and this is how people used to travel. And from there, we have become so modern, and we have become scientific. We have contributed to space research. We are in the forefront of AI and robotics. We have created large highway network, large sea link. We put Chandrayaan on the moon. All this has been possible because the country moved forward, because it said yes to the new technology and innovation. And I think the same thing we need to adopt as an anesthesiologist to all the new innovations for accentuating patient safety. So regional anesthesia was a terminology given by Harvey Cushing. And if you introspect, if I introspect, if regional anesthesia did not grow, and what will be me and what will be my patients? I can't imagine an anesthesia care without regional anesthesia. So we would have been professionally stunted, and our degree of incompetence would have been high, especially when we deal with critically ill patients, and patient safety and comfort would not have been the same. So it becomes very crucial for advancing the quality of patient care and for excelling in the profession that we do. We need to embark on the journey of mastering ultrasound guided blocks and peripheral nerve stimulated guided blocks, because the single most important reason for a patient to be very uncomfortable in the perioperative period is pain, and we as angels can take care of this pain. I would like to quote Dr. Ravindra Bhatt, our head of the department in Ganga Medical Center, who initiated this program, on arrival block for every injured, which we started way back in the year 1998. From then on, we initially used needles to do blocks. This was a case of hip fracture, and we are giving a femoral block using a landmark technique. And then we moved on to the peripheral nerve stimulator, And we started effectively blocking our patients. For example, you see a shoulder surgery, a block being given with the help of a peripheral nerve stimulator. With the help of peripheral nerve stimulator, we also put perineural catheters. And that was an era between 1998 to 2006 when we extensively used this. But it's been a phenomenal journey from then on. And pain alleviation has become such an important component. And with rapid resurgence of regional anesthesia and analgesia, with the advent of ultrasound machine, with the advent of the catheters, it has been a great journey. And the peripheral nerve stimulators also have seen phenomenal growth. And this is the SNSE technology, which has been incorporated into the peripheral nerve stimulator, has made the blocks more accurate. A lot of nerve located needles are available, and they're insulated, and they have an excellent short bevel needle tip. And there are quite a few improvisations that has happened in this field. But the major change has happened because of use of ultrasound. And I urge every single anesthesiologist who is listening to this talk to embark on the journey of making ultrasound their own. And it becomes important that you know the knobology. The current machines are so friendly to us that it's very, very easy to master the knobology with very few basic controls. And the depth, the focus, and the gain forms the inherent component in image optimization with the ultrasound machine. Multiple probes are available, but you know, linear probe is for those structures that we identified, which are superficial for about a depth of about 4 to 5 centimeters from the skin. And you have the curved array probe for deeper blocks. And we have plethora of new there are the plethora of new probes which have been available, which has revolutionized the practice of anesthesia. Then now we have the echogenic needles. The echogenic needles have the ability to improve the visibility of the needle, and this has added a new dimension. And we also have got dual guidance, sonoplex, and now it has become important also to look at preventing nerve injuries. And we have this triple monitor. So you have the ultrasound machine, you see the structure, you use a peripheral nerve stimulator to move towards the identified neural tissue, and then you put this particular equipment, the injection pressure monitor, between your syringe, which injects the drug, and the needle. And this is something which has made another revolution in decreasing the complication. So, for example, the B-Smart, which you see on the left side, shows color-coded PSI. And if we know that if the PSI becomes more than 15, then you're not supposed to inject because the tip of the needle could be within the nerve. And what you see in the right side is nerve guard. Here, when the PSI increases more than 15, it shuts and we cannot inject the drug. So this is a mechanism, safety mechanism to prevent inadvertent intraneural injection into a neural tissue. There have also been advancements with the 3D ultrasound, 4D ultrasound, and now we are so fortunate that the new machines have incorporated AI, and also this machine, the Sonix GPS, will help you to track the needle. So it's an excellent new addition, and it's very good for the newcomers and beginners that it will help us to track, and it will give the guidance. It will tutor us to go towards the nerve. And if you see, when you insert the needle, you will see how the needle is getting guided and the needle is marked, and the projected trajectory is also visible. This all enhances the ability to do the block without much guidance and assistance. And because of the use of these technology, especially regional anesthesia, it has enhanced our professional scope. I quote this patient very often because we had a 42-year-old patient who was obese, had systemic hypertension and diabetic mellitus, coronary artery disease, triple vessel disease. He was advised to CABG, but he was not keen to undergo one. He was hypothyroid. His ejection fraction was 42% on arrival. He had also had moderate aortic stenosis when we did the echo. 6 months before, he had a deep vein thrombosis. So since then, he has been on tablet warfarin, and his INR on arrival was 2.3. He was on dual antiplatelet therapy because of his coronary artery disorder. And after lunch, he had a fall. He was full stomach, and he had a fracture dislocation ankle with an open wound. And when he arrived, he came with a BP of 240, 130 and a pulse rate of 140 per minute with severe pain. So this case scenario would have been extremely difficult if we have not mastered regional anesthesia. So here is the place which showed how you can make an ASA grade 4 patient look like ASA grade 1 by mastering the latest advancement and technology. So we decided to go for, after the written informed consent, after informing the patient, the attendant, and the surgical colleagues, we went on to administer an ultrasound-guided popliteal sciatic nerve block for this patient. And within 20 minutes after the block, you could see the blood pressure come down to 140/80, heart rate come down to about 90, absolute pain relief, and the fracture dislocation was reduced. And there was a lot of swelling. So the surgeon said that we will go for a definitive fixation after 48 to 72 hours when the swelling becomes less. And after 72 hours, again under the block, the whole fixation was done. This clearly indicates that an anesthesiologist who is proficient enough to do a block using an ultrasound and a peripheral nerve stimulator is a notch above the others in giving the best possible anesthesia for a patient who's challenged him with several comorbidities. So this is an example of how you can make a difference in the perioperative period. And slowly, we have gone to the extent of using this technique for every single surgical procedures that you do. So all shoulder procedures, now we do it under the brachial block. Even if we do it, arthroscopies are done under GA, we also give a block. And now we know that when we do an interscalene block, there can be an involvement of the diaphragm because of the phrenic nerve, and there could be a possibility of hypoxia. So now we have gone for selective phrenic nerve sparing brachial block. So lower volume interscalene, superior trunk block, or what we call it as the scud block, where you just block the upper trunk and the supraclavicular nerve, the supraclavicular block, costoclavicular block, infraclavicular block plus suprascapular plus axillary nerve block, posterior approach of suprascapular and plus axillary block. What I'm trying to kind of emphasize is we have gone to procedure specific, site specific blocks, and also we have graduated that if the patient has got pulmonary compromise, COPD, then you still further you refine your technique and you go for phrenic nerve sparing block. So it's a new conceptualization that based upon the tissue injury, the dermatome, myotome, and the osteotome, you decide which block to give. And then when you decide to do the block, you also assess the clinical parameters of the patient. And if you think that one side diaphragmatic palsy can result in hypoxia, you graduate yourself and go for much more selective block, which produces excellent quality of regional anesthesia without compromising the respiratory function. So these are examples to show how the regional anesthesia has progressed phenomenally over the past few years. And I'm just going through what I described of using selective blocks for patients with shoulder. And now we also have clinical pathways, moving from shoulder to a geriatric hip. So we have clear clinical pathways, and irrespective of the age of the patient, if the patient comes with a neck of femur with an intact capsule, very less pain, so we go for on-arrival ping block. If it's neck of femur with capsular disruption, we either go for a PING or a suprainguinal fascia iliaca or a femoral block. If they have an intertrochanter fracture, we either go for a femoral block or a high volume PING. And if they are intertrochanter with subtrochanteric extension, we go for a femoral block. So we have defined based upon the X-ray. X-ray is not only for the surgeon, it's also for an anesthesiologist to know what type of fracture, what type of nociceptors will get involved, and what is the distribution of the neural supply and which block that I would choose from. This is yet another progress of being very specific in what you want to deliver to the patient. And when you clearly adopt pathways like this, you will see excellent postoperative analgesia in our patients. And this is on first POD on a 110-year-old who underwent a hip fracture, who is all set to ambulate. This is the difference that regional analgesia makes to our patients. And initially, we started with nerve blocks for the extremities, the upper extremity and the lower extremity. Then we graduated, and now it's the era of interfacial plane block. And so thoracic surgeries and abdominal surgeries have all been given excellent quality of perioperative anesthesia and sometimes analgesia as a component of multimodal analgesia in the postoperative period for thoracic and abdominal surgery. One classic example is the commonly performed breast surgery. So it has been shown that not only the quality of perioperative pain, it has also shown that regional anesthesia improves excellent outcomes because of reduced stress response, reduced need for anesthetic agents, and improved outcomes. And this original article in Regional Anesthesia and Pain Medicine said, impact of regional anesthesia on recurrence, metastasis, and immune response in breast cancer surgery, indicating that RA is extremely good in having an appropriate immune response. So again, we define what that you want to do in breast procedures, and we have several options starting from thoracic epidural, thoracic paravertebral, simplest block, the erector spinae block, PEC 1, PEC 2, serratus anterior plane blocks have revolutionized the pain relief in breast surgeries. And I wanted everyone listening to the talk to graduate to that level where you become proficient enough to administer all these blocks and keep this a part of your armamentarium. And you discuss with the surgical team, find out what kind of surgery that they're planning and what would be the involvement of the level of, for example, if it's a small node in the breast, then you can go for simple block. But if it's an extensive one, then you need to go for graduate yourself to a PEC 1, PEC 2 plus serratus anterior plane block. And I'm extremely happy that each one of you should embark on the journey to go through all these blocks, which have completely revolutionized the practice of perioperative care. So the pecto-intercostal plane blocks have become very crucial and important. These are the parasternal blocks, which are used for patients undergoing sternotomies. So this is made enhanced recovery after surgery, after open heart procedures where sternotomy is needed. And these are all C1-2-1 blocks, the interfacial plane blocks, which has revolutionized the practice of pain relief post sternotomy surgeries. And in spine surgeries, we have found erector spinae block to be extremely handy. And when we do our major reconstructive spine surgery like scoliosis, now we have gone for a 4-quadrant erector spinae block plus target controlled infusion and total intravenous anesthesia. And even after 4 to 5 hours of extensive surgical procedures with phenomenal amount of tissue destruction, at the end of the surgery, you would see an awake patient smiling because of lack of pain. So ESP has revolutionized the practice of our multimodal analgesia and post-op pain relief in major spine surgeries. And all abdominal surgeries have been made pain-free because of the advent of tab block, rectus sheath block, and iliohypogastric ilioinguinal nerve block, and the commonly performed the deeper blocks, the QL blocks, completely revolutionized. The QL blocks are good because it gives both visceral and somatic pain relief. And there are plenty of articles which have come in. And we are also improvising on the paravertebral blocks. So now one of the problems was when you do a paravertebral block, there was a possibility of a pleural injury. And so now we have gone to, if you see, if I inject here, this is the pleura, this is the lung, the yellow color is the pleura, this is the thoracic paravertebral space, and there was a possibility when we deposit the drug here, the needle may pierce the pleura. So now we have got the intertransverse process block where we deposit the drug superficial to the ligament here, so that you don't pierce this ligament which is between the two transverse process. So you place the drug superficial to this, and the drug seeps through this ligament and essentially results in a thoracic paravertebral block. But we are happy to share that we are devising strategies to prevent complications and finding out the effective ways of producing good analgesia with least complications. And in the perioperative period, this also can be used to decrease pain during rehabilitation. This was a patient who had multiple surgeries for his reconstructive lower limb, which was a crush injury of the lower limb, and he developed a chronic pain syndrome. And so we put him on a continuous popliteal catheter, and to break the pain of the severe post-surgical pain that he had, and he had excellent results. So once you master the art of regional analgesia and anesthesia, it extends right from your on-arrival block in trauma for an intraoperative block, whether you do the block purely for anesthesia or as a part of multimodal analgesia. As I said, initially you started with upper limb, then went you back to lower limb, and now you use interfacial plane blocks for thoracic and abdominal and spine surgeries, and which has completely revolutionized the outcomes in several of these patients. So we are extensively use this in trauma on arrival, and thanks to the advent of cadaveric studies, and the Academy of Regional Anesthesia has got a cadaver board which is headed by Dr. Sandeep Diwan from Pune. So cadaveric studies have given us greater insights to know about the spread of the drugs and what would be the ideal drug to be given. So we are making a rapid progress in the learning of ultrasound guided regional block. And we also now have simulation based learning, and a lot of needle trainers are available. I'm happy to share that in our institution, we train close to 80 fellows every year in regional anesthesia, including international fellows through the World Federation of Society of Anesthesiologists. Training hands-on for a period of time gives the courage and conviction to do the block appropriately. But in the journey of using these blocks, it becomes important that you keep on auditing your work and see whether you can make your blocks work better. You can go for a different block. You can enhance the volume. You can add adjuvants. So you can keep on improvising your clinical work based upon the feedback from your patients, and try to find out the best blocks that you would possibly administer for your patient population to make them pain-free. So regional anesthesia and analgesia has a huge role in the modern anesthetic practice. It's extremely useful to relieve acute pain, and when it is administered before the skin incision made, we call it as the preemptive analgesia. And when it is done, it makes the surgical field excellent, and it decreases the intraoperative requirement of the anesthetic agents, and we see an excellent postoperative recovery. In the postoperative period, even if you do the case under a general anesthetic, it becomes important that you incorporate a regional analgesia technique along with that as a part of the multimodal analgesia, which decreases the requirement of the opioid. Patient feels very comfortable, so the sense of well-being. They start early ambulation, the less chances of deep vein thrombosis. They sleep well, they have an excellent appetite, they participate in physiotherapy, they have decreased cognitive dysfunction, and also their hospital stay becomes less. So it gives such a positivity for the patient, and also using regional analgesia has been contributing to environment sustainability in decreasing the inhalational agents that we use, increasing the carbon footprint that is produced because of anesthesia in the perioperative period. So I strongly urge every single anesthesiologist in Kerala who's listening to this talk should make regional anesthesia and analgesia as an inherent component of their clinical practice. And when you do this, you really become iconic in front of the patient because of the comfort that he gets. And the surgeon, after some time, will realize that all his patients are so comfortable in the perioperative period, and he would surely consider anesthesiologist as an iconic branch which can produce far-reaching consequences rather than just pain alleviation. So I sincerely thank all of you for joining this session, and I'm sure Dr. Benil and our Honorary Secretary, Dr. Vijesh Venugopalan, will continue this journey of enriching members of ISA Kerala State Branch, and I'm sure together we will create an organization that stands for patient comfort and good outcomes. Thanks for the opportunity, and I look forward for several nice initiatives from the stable of Kerala ISA. Thank you so much.
Thank you, Bala, for the excellent opening session. Bala, please stay back. We will take up the questions at the end of the session. And now we move on to the ISA, the prestigious ISA Kahoot quiz. And your comments will be displayed, even on your YouTube comments, live chat comments will be displayed. And you can be ready with your questions and on at the end of our sessions for the Q&A sessions. So next we will move on to the Kahoot quiz. Then Bala Bhaskar lecture by the Dr. Bala Bhaskar. So over to our academic coordinator, Dr. Sanish PJ, for the ISA Kahoot quiz.
Thank you very much for the opportunity. I thank the ISA Kerala State Chapter President, Dr. Benil, and Dr. Vijesh, the Honorable Secretary, and all the office bearers of ISA Kerala for initiating this online academic event named AnaesthesiaCONNECT. And Kahoot quiz will be an integral part of all the weekly Saturday evening programs. So this will give you an excellent opportunity to test your knowledge, compete with your peers. There is no distinction between postgraduates and consultants. So we all take part in this festival of knowledge. There will be short Kahoot quiz every week with AnaesthesiaCONNECT. And what is there to win? The first prize winner will get a cash prize from ISA Kerala State Chapter. Wherever you are, because we would like to extend this opportunity to whoever is attending from anywhere in India or anywhere in the world for that matter. But only thing you need to remember is when you join, make sure you give the first 4 letters of your name, first 4 alphabets of your name, followed by your 10-digit mobile number. Then only we'll be able to identify the winners. Otherwise, there will be too many dinosaurs, too many lotters and all. So let's not go into that. First 4 letters should be your first 4 alphabets of your name, and then your 10-digit mobile number. And there will be only 5 questions. Remember, only 5 questions. And each question you will get a time of around 30 seconds to answer. Faster you answer, greater will be your mark. Okay, so even if many people give the right answer, whoever answers faster will get more scores. So we'll have a scoreboard and a podium arriving at the end of the session. And with that 10-digit mobile number in your username, we'll contact you and we'll offer the cash prize. And top 3 winners are also eligible to get a e-certificate of participation as winner of ISA Kerala Kahoot quiz for the week. So we need to contact 3 people, the 3 top winners of ISA Kerala Kahoot quiz. Are you ready? So I am ready to go. So the game pin is being displayed in the bottom part of our screen. Anytime anybody, even if you join late, whatever it is, who knows, maybe with 4 questions, you might still become the topper. Okay, so it's a game of accuracy and quickness. Okay, let's start with the first question of ISA Kerala Kahoot quiz time. November 1 edition. 3, 2, 1, go. Yeah. So here's the first question. This is the quiz mode. Yes. In 2025, WFSA's annual theme will raise awareness of the indispensability of anesthesiologists in PAE, pre-anesthesia evaluation, CPR, cardiopulmonary resuscitation, EECC, emergency essential cardiovascular care, anesthesia workforce. Your time's running up. Yes. Another 16 seconds. Yes, all have answered. Okay. So 5 got the right answer. Essential emergency cardiovascular care. Essential emergency critical care. That is something that we emphasize in this year 2025. So all others are not an emphasis point at this point this year. Okay, here we get the scorecard. So being the first one, I think Shruth, is it Dr. Shruti? Yeah, okay, it's the winner at this point of time, but we have 4 more questions to go. Yes. Second question, 2002 Moscow theater crisis, the carminative gas was used during the Russian military action. Identify that. As per the available literature, what is it? Sevoflurane, fentanyl derivatives, organophosphorus, nitrous oxide. Interesting question. Accuracy matters, but swiftness carries extra weightage. First accuracy, then your swiftness. Is it sevoflurane, fentanyl derivative, organophosphorus, or nitrous oxide? The answer will be based on the available literature. Yes. Very interesting. I think only 1 person got it right. It's fentanyl derivative. Previously, it was thought to be sevoflurane. But I think nitrous oxide, I think majority went for nitrous oxide. It's amazing. Okay, this fentanyl derivatives. So the article I have shown will give more details into it. Remifentanil and similar fentanyl derivatives in aerosolized form. That was the mystery factor with this event. So who keeps the topper list? Leaderboard, I think SRUT is probably Suti is holding his her position, I believe. Okay, fine. Let's move ahead. Next question. Pick out the false statement about levobupivacaine. It's amide type local anesthetic, lower risk of cardiotoxicity and neurotoxicity. Yes, enantiomer, reversibly blocking voltage-gated calcium channels. Pick out the false statement about levobupivacaine. Easy question, I thought. Yes, majority got it right. This is the wrong response. The answer option D. It is reversibly blocking voltage-gated sodium channel, not the calcium channels. Okay, how is the leaderboard? There is small upset. Yes, a new person on top after 3 questions. JM. We'll find out who is JM if he or she remains in the top place after the entire questions. All the best. Keep going. I think SAJE is still there at the second place, and GK has climbed up. Unfortunately, we won't be able to trace you, because next time what you do is first 4 alphabets of your name followed by 10-digit mobile number, please. Okay, the next question. Question number 4, name the Indian organization, a member of ILCOR, formulating Indian guidelines for CPR and emergency cardiovascular care. Is it IMA, ISA, IRCF, or ICA? Must be a straightforward question for many. Who formulates Indian guidelines for CPR and ECC? Is a member of ILCOR representing India. Okay, few more answers, we can go ahead, or we'll wait for another 13 seconds. Remember, accuracy matters, but quickness or swiftness will get you more points to be on the top of the leadership table. Yes, yeah, majority got it right. Indian Resuscitation Council Federation is an ILCOR member, part of the ILCOR, formulating Indian guidelines for CPR and emergency cardiovascular care. You'll see the leaderboard. Now, a new winner. GK is the new winner. I don't know how to contact you, but since being the inaugural edition, if you happen to be the top after the next question, please drop in an email or contact us at your earliest, so that we can announce the winner at the end of the session. Okay, so here we go, the fifth and final question. Yes, which of the following parameter is not included in Wilson's risk sum score? Is it weight, neck circumference, jaw movement, receding mandible? Q. We are in a hurry to move to the next session, Journal Club. Afterwards, we'll announce the winners. Yes. Neck circumference. I don't know why you got it wrong, the majority of people. Okay. So we'll stop at this point. The end score will come to at the end of today's session. So I'll hand over the podium to Dr. Rajesh MC for the further proceedings. We'll keep engaged in ISA Kerala Anesthesia Connect. Whatever you text in the YouTube or Facebook will be displayed onto the screen. Kindly do not give the answers of the quiz in your chat. The chat is basically for your responses. Okay, fine. Over to you, Dr. Rajesh.
Thank you, Dr. Sanish. At the outset, I should congratulate and thank Dr. Binil and Dr. Vijesh for taking ISA Kerala State to next higher levels. So my job is to introduce Professor Balabhaskar. I don't think Professor Balabhaskar sir needs any introduction, especially for the Kerala ISA circles. But anyway, for the benefit of young postgraduates, Professor Balabhaskar is the Professor of Anesthesia at SWIMS, Bellary, Karnataka, is the Deputy Editor for Update in Anesthesia, published by the World Federation of Society of Anesthesiologists. So was the past Editor-in-Chief of Indian Journal of Anesthesia, past President of Indian Society of Anesthesiologists, and he is at present editorial board member of Journal of Airway, Journal of Acute Care, in addition to Indian Journal of Anesthesia. He was instrumental in formulating ISA practice guidelines, especially with fasting and pre-op investigations. He was the brain behind the formulating all these guidelines. So over to Balabhaskar, sir, for the Journal Club. But a couple of words about the Journal Club. It is not just a routine academic exercise, but it is the heartbeat of evidence-based learning platform. So it basically bridges the gap between the research and clinical practice
and it critically analyzes the research and its clinical implications in our day-to-day practice. And it promotes evidence-based practice and enhances the clinical appraisal skills. Over to you, sir, Professor Balabhaskar.
Good evening to everybody. I thank the ISA Kerala State Branch for asking me to speak about this topic, Journal Club, how to make an effective presentation. I would like to declare this is very specific to this presentation, that it is basically addressed towards the trainees in specialty of anesthesiology, and I have used in the second half of presentation an open access article which is cited purely for academic purposes. The remarks, of course, are not intended to be against authors or editorial group or the journal per se. And it is, as I said again, it's like a critical analysis. And for some small illustrations, I have used ChatGPT. So because this topic will be a little bit initially difficult to understand for the trainees, it is advisable that they either download the presentation or watch the video in the YouTube from the Kerala website. And you can, at the end, I've given a small tip. You can prepare an Excel sheet based on whatever you have learned, and it will become a ready reckoner for you to present a journal club in future. So what is a journal club? When we are speaking about journal club, it is a formal discussion, a structured discussion where a selected research article from a biomedical journal is critically appraised. Right? So when a postgraduate is asked to present a journal club, he will be in confusion in the beginning. And the purpose of the journal club would be for the PGs and everybody to understand about the published articles' validity, applicability, potential relevance in practice, whether it can affect the practice, we can implement the outcomes in your practice, apart from the scientific understanding. And of course, anything which is published as a research promotes evidence-based practice, and it fosters a critical thinking and a sense of collaboration and knowledge sharing in the person who is presenting. And of course, it's a mandate of National Medical Commission and NBEMS for the postgraduates, and it could be part of the continuing professional development for the specialists also. So what I will try to do is make you understand first how an article should be selected, and later on how it should be appraised, and simultaneously what are the important points in presentation. So when you speak about selecting an article, of course it has to be relevant to a specialty. If you are speaking as an intensivist or anesthesiologist or a pain physician, pick up an article from that specialty. Should be interesting, first of all. When you present, should not be thrust a topic. You should know what is interesting for you and for the institution, and generally pick up very novel studies, not useful to present a run-of-the-mill article. Could be attractive for clinical practice also. And if you are presenting for example, a freelancer group, definitely it should be one which is targeted towards that group. And always pick up a recent article which is published, for example, in the last 6 months, ideally, and not earlier than last 2 years. And pick up high impact journals. Don't use those with are of suspect quality or metrics. It should be well respected and it should have been peer reviewed, right? And accessible full text, that's very important. Picking up and then trying to share and display also will be a problematic later on. And identify the most well-researched paper in that publication. So for discussion for today, we'll be picking up a randomized controlled trial. It's the best one as an example and for presentation purposes. We can also use cohort studies, case control studies. But on the other side, even we can nicely discuss systematic reviews and meta-analysis, but it's outside the domain of the trainees. It's very difficult, it's more comprehensive. And we normally don't speak about narrative review articles, or maybe sometimes small case reports. There are inadequate points for discussion and critiquing. Anyway, when the article is being picked up, of course, the trainee or the PG would get the advice inputs from the moderator or the staff on its academic significance for the trainee and also for its relevance to practice. So once selected, it's not that you just come and present as a seminar. You should share the article early with your co-faculty and the co-students or the audience who are going to participate. In the early years, we are giving printouts to all our colleagues, and you are also preparing. Now we can share the soft copies also. It could be the whole article, it could be a summary which you can prepare. But at least if you have difficulty in the initial phase, you can use the whole article also. So once the article is selected, we should decide to appraise the article. So what is this appraisal? Appraisal is the act of assessing something or someone, and if it is an article, whether it is worth reading, right? So we can recommend to others that this is like this in this particular article also, and what is the good and bad of the article. What is the topic, how they have chosen the topic, what did they want to find out, how did they conduct the methodology, what were the outcomes, right? What are the statistical types, right? And generally, whether how much is it open for discussion and updates. So when we do an appraisal in a more systematic way, it becomes a critical appraisal. It's a systematic process of examining a research study to evaluate and judge its trustworthiness, validity, value, and relevance. So when I say trustworthiness, it refers to, for example, data. Validity means when the data is analyzed and presented in a perfect scientific manner. Value is again the scientific part, and the relevance is for the practice. So what you try to do is pick up both the good and the bad in the particular published article and try to discuss in a healthy way. It is never a criticism, and it is criticism implies that it's about inferred bad aspects, right, from your point of view. So there would be a systematic approach to critical appraisal, as I told you already. It would start from the research question that the author has prepared while publishing, while researching, whether it is correctly framed, planned, and implemented, and whether he has got a clear hypothesis, and the study design is already declared, and he has implemented the whole protocol of the study design, the statements on regulatory recommendations, whether it is included, how the selection bias and other things are done, are taken care of, outcomes, whether they have been clearly defined, what are the measurements, as I told you, data collection, display of data in a table or the graph. So many things are there, and especially statistics also is very important part for us to read a little bit and try to understand and even comment upon. And discussion is very important from the time when the results are being, section is over, whether he has discussed properly, he or she, the research question has been addressed properly, the aims and objectives, the methodology has been good or not, what are the mistakes in the inferences, whether he has used the correct data to come to a conclusion. So all these things are very important as a systematic approach. So this about what I have given about 11 points here, which are also expanded. So there is a greater expanded set of things which are available in, for example, reporting guidelines available for different types of research articles. Because we are discussing about randomized trials today, we have got reporting guidelines from Equator Network, or it is from the CONSORT group, Consolidated Standards of Reporting Trials, where there are, this is an updated one. We have got a consort checklist 2025 and an expanded checklist. Many of us would remember there were about 25 points previously, and now it has got about 30 points. And all these 30 points are expected to be part of a well-conducted randomized controlled trial. So, and this list we are supposed to tick as an author, for example, and I publish it. So if we are able to appraise based on these 30 points and see whether they are there or not, addressed or not, so it becomes easy for us to critically appraise a published RCT. So, for example, this is at the beginning of the consort list here. It is the first point. So it starts from title, the abstracts, the limitations in this part. Then it goes on to population recruitment, inclusion, exclusion, everything is included. We can download this list from the internet. It is freely available. Okay. And broadly, of course, we can not go strictly by 1 to 30 points, expect that point 1, 2, 3, 4, 7, 8, 10, and are there present sequentially in a published article. So, but we have to find out from the headings which are provided as a standard protocol in the published article. For example, in a published article, you'll have the title, right? You got the introduction, methods, results, discussion, references, and in the beginning you will have abstract and all. Okay, so each of these sections would contain the important 30 points which you are looking for. So in the first step, what you can do is just screen and read out for yourself. We in the article, we can remember by the Takar mnemonic and the Imbra mnemonic. So what is this? I will tell you in brief. So then we can do what you can do is you can say the point 1, point 2, point 3, point 4 is attended or not attended by the author. And if it is attended, whether it is properly attended and are there any problems, where is lack in our gap and also. This is how we can understand each section in the published article. So when you say Tucker, so it is for title, abstract, keywords, acknowledgement, and references. So you go from each point here. For example, the article shall represent basically what is the design, what is the population, okay, which set of patients, patients posted for total knee arthroplasty, and what will be the primary outcome for that particular study. And the design of the study is very important. So if you look at this article, here they are talking about analgesic efficacy of ultrasound-guided genicular nerve block with a combination of adductor canal block and genicular nerve block and RCT, randomized controlled trial. That is very important. You should also look into the author and affiliation, scientific institution. Try to see. So I am not telling that only the best institution should publish the best articles, but it helps for you to later on decide about even getting in touch with the authors and trying to see, update yourself. And you can also look at the journal publication dates and the year and who are the contributors, because I said you should be picking up a recent article, right? So then we have got the abstract, generally which is the initial summary. It's like a ready reckoner. So it gives the best impression. It guides you to read or not. So I do like that only. When I open, if abstract is good, I decide to go forward. So it is like, if the quality of the article is good, the quality of the research is good, it is clearly reflected in the abstract also. It would include the basically why the article and the research has been conducted, how the populations have been picked up, how randomization was done, what were the two group studies, what were the interventions and the control group, sample size. They would also have mentioned briefly the statistics that has been used. So all of this have to be understood and read out and highlighted when you present in the journal club. And major data are provided, not the small data, because there is a word count limitation, for example, 250 words, and the conclusion have to be focused in this section. So keywords also are provided in the bottom. So they definitely have direct bearing on the quality of this article. But what I would like to say is, if the authors have used the correct keywords, we want them to have used mesh keywords, one of the types, medical subject headings, which is part of the NLM vocabulary. So if these keywords are just typed and in a search engine, for example, in PubMed, so you are more likely to get similar articles to get clarifications for yourself. You've got some doubt, and more recent articles after publication would have been there. You can also get those articles. So this is the importance of trying to read out keywords as part of the critical appraisal. And there is acknowledgement. We are jumping towards the end, but don't worry, it's good. It's a good part of mnemonic. So these are very important. Financial support and sponsorship has to be clearly declared in conflicts of interest, because it is part of the ethics and the credibility of the particular research and publication. So disclosure, against nowadays we are using artificial intelligence. I spoke about ChatGPT, right? So, but they are not allowed to be part of the presentation. And if it is indeed mandatory or required, you must clearly acknowledge. Okay, it reflects the overall. This part reflects the quality of the review process and the publication. And the references is or last part, occur. So what is important is it reflects that the author has used a lot of past evidences in preparing and implementing and discussing the particular project. And the reader, when I am there, I am able to have cross-reference and reference chasing. See, there is a word limit for an RCT, about 2,500 words in generally. So an author, even if I am an author researcher, I will not be able to give all the details in the publication. So I would have left some things unsaid. It's not negative thing about the author. So if I am the reader, and I will be able to go to this particular article and try to verify, understand myself. So this is very important in terms of references. But suffice to say, you would have seen that sometimes the reference is totally missing, and the numbered reference is of a wrong article, or there is an article with a wrong link. Okay? And sometimes when online resources are there, if you try to open, it will show as error, no longer available, or it is moved to some other place. So this is what happens. If it is there, then it also reflects that there is a poor preparation from the author side. Okay. Then after you have spoken about and understood about the Tucker mnemonic and how to analyze, go to Imbrad mnemonic. This is the most important one. It will cover, the Tucker is basically the initial part and the summary and other things. Imbrad mnemonic will cover all aspects of appraisal, plus 90% of them in full detail. For example, I refers to the introduction. It introduces you to a particular problem and what is known in the previous evidences and what is missing in the previous evidences, and based on that, what the author wants to find out as objectives and create an hypothesis. For example, this particular article is about I think spinal anesthesia for patients for total knee arthroplasty and analgesia, okay, with two different techniques. So what they have said is knee osteoarthritis is common. It is very painful. Multimodal analgesia have been tried. Regional anesthesia has been tried. Okay, different options are available and combinations are available. Okay, then they have said they have created a hypothesis also that there is genicular nerve block has been an upcoming topic, and the block is closer to the knee, and you have got lesser risk and better quality of analgesia probably when it is used as part of multimodal. Okay, and they have said there is a limited knowledge about this particular block. So they wanted to test the hypothesis that performing the genicular nerve block, in addition to, for example, routinely used adductor canal block, will reduce the 24-hour opioid consumption. This is what they created as the hypothesis. Then they said they have got the objective to find out the opioid consumption in the first 24 hours, the VAS course and all as secondary objectives, right? So in the method section, the first part, I got a series of sections in the methods. Is the most important one, most important one in terms of critical analysis. Initially, we must identify that everything, mandatory regulations have been met with. So Institutional Ethics Committee approval with number and date of approval, then the CTRA number and date of approval, the patient consent part, the duration and where it was conducted, and the design of the study also have to be clearly mentioned. So the clear protocols are available. What is missing in this particular section? Actually, I have picked up from the published article only. So what is missing is actually I found this part should have had clarity about and mention about the design of the study. That is a randomized control trial that they have not entered. Okay, but it is important to identify all these points also. And when you go forward, there will be discussion about the mention about the methodology. So they have picked up this many patients of IASA physical state of this age group, right? Undergoing what type of procedure and what standard anesthesia, okay, a GA or spinal or whatever. And they have shown about inclusion criteria, exclusion criteria also would be shown, right? So in fact, if you see here, I have highlighted use of opioids for chronic pain was a exclusion criteria. So this is one of the mistakes that is always seen in some of the researchers. So if this part has not been included and the patient has been taking analgesics for some other reason, that becomes what is known as confounding factor. So if there are confounding factors which could affect the choice of the subjects and the outcomes, they must also be clearly required, mentioned as a confounding factors. Imagine patient is on long-term opioid and one set of patients or many patients who are not unaccounted for and they got better analgesia or worse analgesia. It affects the statistical interpretation. And exclusion should be minimal exclusion, right? If you have got a whole list of inclusion, and if I say, I want to exclude patients with diabetes mellitus, hypertension in patients who are going to undergo osteoarthritis or the knee. Obesity, you want to say, I want to rule out, exclude. Is it correct in a practical sense? It's not, right? So we have to have as minimal exclusion criteria as possible. Then group allocation must be clearly defined because we are talking about a randomized control trial. See, these people have clearly mentioned about how computer-generated randomization was performed. Then allocation concealment was done in a sealed opaque envelope technique, and how the blinding was performed. So person who was performing the procedure, person who was collecting the data, the person who was preparing the drugs, and also these are second blinding, third blinding also is possible. So this is very important. If it is not declared and found, then it represents a poor quality of the article. Then if you see here, they have not mentioned about the computer software that is used for randomization. That's also expected to be shown. This is the most important part of a randomized control trial outside of the academic part. Then they will speak about the group-specific procedures. So here, this article, they have used ultrasound guided block. In one set of patients, they have used basically the adductor canal block alone, and in the other set, they have used adductor canal block with the genicular nerve blocks. And they have also clearly mentioned about the drugs and the doses, and the device also is very important. What was the type of the probe, the frequency of the probe, the make, okay, the type of the needle. So everything has to be clearly defined, because if somebody wants to replicate this study, they should be able to know what has been done correctly. Okay, even the drug dose route in terms of mLs and percentages of which local anesthetic, which additive has to be clearly maintained. See, all these things have been shown here. And whenever a new technique is performed and is shown as a publication, even the illustrations and videos are also sometimes available, because you have to understand. I don't, for example, if I publish a spinal related article, I don't put an illustration, right? So that's how it is. And next, they will also speak about the common management. I said all patients undergoing spinal anesthesia. So what will be the preoperative evaluation, pre-op investigation, pre-medication, right? Preloading, okay? These are uniform for both the groups. And in fact, what you should also understand is when I say two groups, I want to text some analgesic agent. One group would receive the analgesic, the other group would not receive. So that is not correct, that is not ethical. So always both the groups will receive background analgesia. For example, these people have spoken about oral paracetamol and salicylic acid 2 hours before the surgery. And people also mentioning about the monitoring. They say it is taken for granted, so it is not acceptable. There should be a routine monitoring that has been done, that has to be mentioned, and also specially what is monitored for in a particular patient. Okay, that's very important when we present it in the journal club also. Then the outcomes. So they have said about cumulative morphine consumption in initial 24 hours as a primary outcome. So all the studies shall have primary outcome and secondary outcome. Primary is the one most important thing which you are able to want to find out as part of hypothesis. Then they have spoken about multiple secondary outcomes, whether they have been entered or not, and why they have chosen the primary outcome, which is this. For example, these people could have very well used time to request for the first rescue analgesia, that's the duration of analgesia. But they have chosen to have morphine. So why morphine, duration, morphine consumption is taken as a primary outcome. So that sort of justification also you should be able to find out. And for all these outcomes, how they were measured and how they were graded and how they were classified. So all these things should have been published, and they should have been validated. Ramsay sedation scale, which is a widely accepted, validated score. I cannot say Balabaskar sedation scale. Wrong. Okay. So there should be validated classifications and gradings which are being used by the authors. Otherwise, it's not acceptable. I am doing in 30 patients and 50 patients telling that this is the system. It's not correct as per the current practice and overall. Okay. So, and even they have spoken about the rescue analgesic for the patient. If patient had, for example, was scored more than 4, what they did and how they have done. So this is important for to understand. And data management. All the data have been collected from the research, and how they put it in Excel sheet, and what are the, for example, reference, wherever they have put it, and how they have cleaned the material. So whichever the descriptive statistics that they used, excuse me, it were the inferential statistics that they have used. So look here, they have used, and what software was used, and the version. So they have spoken about SPSS 29. Then these are continuous, the quantitative variables. Then the categorical variables. What are the tests used for within the group, and two group comparison. So everything has to be clearly checked for. They would have done, whether they have done and whether they have published, you have to clearly understand, right? And in the methods, sample size becomes very important, very, very important. Sorry for this very busy slide, but it is important for you to understand. They must again say what was the software which was used. For example, it is mentioned here. And it is always based upon the primary outcome. All the PGs should understand. So the sample size is calculated based upon a primary outcome, not the secondary outcome, and how the primary outcome is measured. For example, opioid consumption in 24 hours would be in milligrams, right? For example, morphine. Then effect size. Effect size is in one group, imagine that there is 550 minutes plus or minus something of duration without, for example, genicular nerve block, only adductor canal block. And you have to assume, so this assumption in terms of the additional increase decrease in the requirement of morphine. Okay, so for example, if I use about 14 milligrams of morphine in a group, it is only given adductor canal block, and I use only about 6 to 7 milligram in a group where there is a combination genicular nerve block. So this is called the effect size. Okay, or if I assume the duration of analgesia would extend by about 120 minutes as compared to the adductor canal block alone. So this becomes an effect size. And we should look for the alpha error of 0.05. Okay, and we have to look for power, whether they have been clearly mentioned or not. So what is the allowable false positives, allowable false negatives have to be accounted for here, and the dropouts also. In fact, the power they have shown as 95% in this article. Why they have shown 95% power here also should have been discussed. Okay, of course, this is from a previous article, but normally we use 80% power. Why they have spoken about 95% power? Higher power is also always required when it is, for example, more critical analysis or mortality related studies and other things. So some sort of justification would have been ideal with this particular quarter. So results, yes, initially there will be what is known as the consort flow diagram, which represents everything from enrollment, how many were assessed for eligibility, how many were randomized, allocated to two groups, how many could be followed up, how many of them discontinued in between, how many could be subjected to final analysis. Okay, so this is very important, and it will be the first part of the results as a in the publication normally. So this will say in the beginning itself, the reader would know, yes, this person has done a perfect job in terms of recruitment and subjecting the patient for the study and then analyzing it. Then the first table you will see always in the published article is the table of basic demographics and clinical characteristics. So everything will be there: gender, age, BMI, ASA, physical status. So I'm very happy that these authors have used ASA 1 to 3 also. Because definitely, if you see, there's a tendency to speak about 1 and 2 only, ASA, but 3. So in a practical world, real world, there will be patients who are also ASA 3. So you should not be telling I will do always in 1 and 2. Then in terms of the usage of median, interquartile range and range, this is a very beautiful display of data. You would have seen in an average or less than average article, they would have mentioned that 1.5, 2, and a range of 1 to 4.5 or something like that. So this is not acceptable for multiple reasons. The interquartile range is very important when we speak about what is known as the non-uniform distribution of the data. So something like this represents a quality of the data collection and its display also. Because of paucity of time, I'm not going into these details. So we have to look at all these things, and movement is very important. This also I see many times it is missing in many of the published literature. Anything on the chest or upper abdomen or an orthopedic procedure, upper limb and lower limb. So if the patient is still, there is minimal pain to no pain. But if you get the patient to deep breathly, or patient coughs out, for example, chest pain. Chest means chest discomfort will come down. The pain will be there, and patient will not be able to take deep breaths and cough. So it affects the patient's physiology. Similarly, upper limb, we have to think about the movements or the joints, and the lower limb, we want to think about the patient's ambulation, and also these dynamic pain also shall be part of the methodology results and discussion. So this is missing in many of the publications. So this also have to clearly go into the depth, try to see the descriptive statistics also in terms of mean, standard deviation. Again, the p-value in the articles is also very important. General trend is to misinterpret the p-value and trying to say that p-value less than 0.05, it's very, very significant result and all. So one thing to notice, we should be seeing the actual p-values, not very significant, not significant statements. And also try to understand that statistical significance need not indicate clinical significance. For example, you look at this published table only. The first table is about VAS score at rest. Then second one is VAS score at movement at different time points. So if you look at the scores per se, the median appears to be not big, 1 to 2, 1 to 2, and the range also would end at 4, right? The interquartile range, and I think the second one is the range 1 to 3. So when we say VAS of 1 to 10, so normally we say up to 3, it's no pain to minimal pain. And this article shows that every majority of them have got just 3 or sometimes possibly 4. And say it is statistically significant. It is shown as statistically significant. Can you see 0.003, 0.002? So it's important for us to interpret. Okay, authors have done a good job, but whether it is practically so important in terms of the patient relief, right? Then what I have also found was the primary outcome overall was about 24 morphine consumption, and the data are very good. So what was the 5.96 milligram in group 1 and 15.52 milligram in the second group. So this was a primary outcome, and this should have been displayed early. Okay, and there is no confusion about the positive effect of the combination of blocks here as compared to the previous one. And we should also learn which type of data can be displayed in which type of graphical display or illustration. So this is a ready reckoner. If you can read this article, all the details are given. So it's not that I just see a bar diagram, histogram, or scatter plot. What is this ROC curve? They are for specific type of data. Then we'll come to discussion towards the end. I think it'll take just another 5 minutes. Initial part is about the research question, right? So what was the thing? Brief, and even that can be skipped because already we have discussed in the introduction part. There should not be repetition of the points from the introduction, basically, and should start with the findings straight away. Okay, though not if something is not covered in the introduction about the anatomy or the technique or the efficacy, it may be included here, and how the drug or dose was fixed, and any validity scoring systems, and also have to be highlighted here. And the correct references for using a particular methodology, particular dose, and drug also has to be provided here. For example, they have started with the findings of the current study. The study demonstrated that adding auricular nerve block to adductor canal block provides superior post-op analgesia. See, this is what they have given. Then they have said the combination showed considerably reduced VAS scores, longer time to rescue analgesia, less opioid consumption. They have entered here again nicely, but I would have been again happy to see the primary outcome being mentioned first, than the secondary outcome, because we have also clearly shown the same thing in the methodology. And next section is why the findings were there in the current research. That has to be clearly mentioned. So it is our postulation, the author's postulation hypothesis. So why it is more in genicular nerve block group and why it is less in the adductor canal block alone. And if there are references available, they have to put. If it is not, they can infer also. And what are the previous publications in the same field? So authors have very nicely put about Rambia et al. They have spoken about then Axon et al., Dunder et al. So they have nicely cited some other articles. But my one simple comment here would be for us also just to not to take the data from the previous articles. We have to mention about the settings. Were they all from the same age group? Were they all for with a particular technique? Were they all from the same drugs and concentrations? Don't they affect? So we must also, I would love to have some data related to these volumes and the percentages and the additives also. Okay. And we have to discuss what is why the difference has happened between the studies and how the studies are similar also. And towards the end of this discussion, there must be mention about the limitations. What is correct in my study, in the published article, what is not. Okay, authors, for example, in this article have clearly mentioned. We have to find out if there are declared limitations by the author. But we, as critical appraisers or critics, we should also find out what has been further missing, right? That also. So these people have mentioned. The authors here have mentioned that we have used a particular regimen for each of the drugs. However, when different blocks are used, it is a combination of blocks are used. It is very unclear whether the genicular nerve block as a sole block would be effective. And second, ambulation and motor strength of quadriceps were not assessed. See, I told you the dynamic pain. It's very important. The endpoint of a knee surgery, knee replacement is the early ambulation, then the foot drop or strength should be retained. And finally, a smaller size is another limitation, but I don't think it is too much of, if you have calculated the sample size correctly, you should not be putting out the statement. Okay. Then they have also said certain limitations. Optimal local anesthetic volume, which I told you already, they have mentioned. And what is the future scope would have been there, and you should look for that also. They have written that we propose a further high quality research involving large sample sizes and to find out the best combination of drugs and the best volume also. And conclusion would be normally at the end of discussion. Check whether it is focused, is as per the objectives, primary or secondary objectives, as per the methodology, as per the hypothesis. You should not have anything new which are put. It is possible in some articles they have put some new thing which was never part of methodology, some never part of the actual, no results also. Or small results which are very insignificant, never mentioned in the methods. Okay. For example, these authors have mentioned about that combination being better than definitely adductor canal block for post-op analgesia with lesser opioid consumption in the first 24 hours compared to ACP alone in patients undergoing total knee arthroplasty. Okay. So the first part, what they have written is better post-op analgesia. Second part, and lesser opioid consumption. Again, I got small reservation. My primary outcome, I would have anticipated from the author's declaration itself in the methods is opioid consumption. So that could be the first part. The second part would be with respect to, because again, I should think what is this better post-op analgesia? Whether it is in terms of duration, it's in terms of the quality of the block or a combination. Okay. So nothing should be left to the imagination of the reader. So that's more important. And I told you again, because in the methods you have the morphine consumption as the primary outcome, and you have put the better post-op analgesia here. So we should always try to match. So finally, 1 or 2 slides. Preparation and presentation points for a journal club. Number 1, authors should, or the PG should read multiple times the article, discuss with the moderator, check the broad heading of the PACOT and FINER. In the first look, check whether all the consort list requirements are met. Then you go further into the depth, critically analyze each section based on the consort list of 30 points. And sometimes the journals also publish editorial in the same issue. They would have given some critical analysis. You read and try to understand also. And the discussion part, not the discussion part of the journal club. You would have presented everything, but interested audience will have a lot of questions and inputs. Sometimes it takes nearly half of the time. That's very important. And summary has to be provided point wise. And in fact, you can also encourage post-presentation interaction also with the audience. So that's very important. So the final tip is prepare an Excel sheet. Okay, have the consort printout or the soft copy. The 30 points are there. Enter everything in the Excel sheet. For example, in sample size, details available or not available. If they are available, all the points, effect size and alpha and power, everything are clearly entered or not. It's good. And if it is not good, why it is not good, how much it is not good. And if there are no remarks or something is not done, whether it is critical, semi-critical, or it doesn't affect at all. So all these things should have been clearly mentioned. So before I conclude, there is a re-declaration. Put an article purely for academic purposes. Remarks are not intended to be a critical analysis of the authors and the publishers and other things. And it's also an open access article. So thank you very much for the patient hearing.
Thank you, sir, for the wonderful presentation. You started with how to pick up a proper journal article for the academic discussions and how to analyze critically, and whether the findings can be really extrapolated to our day-to-day practice. This was an article came recently in our prestigious Indian Journal of Anesthesia also. So because geniculano block usually ablation, especially the ablation used in inoperable osteoarthritis of knee, whether we can extrapolate to our day-to-day clinical practice, it will be wonderful, because most of the surgeons' requirement or the requirement for the knee replacement is to early mobilization and excellent analgesia. Okay, sir. Thank you for the wonderful presentation and open for discussion.
Thank you.
Also, we are waiting for Bala Venkat, and if he's available, I think he has got some problem with. So we'll anyway, the very nice lecture and an excellent lecture on role of regional anesthesia and analgesia in current day practice by Bala Venkat. And a few comments on that is very insightful concepts are the honorable blocks, the pre-op blocks. That is very useful for the analgesia and patient comfort and everything for before the definitive procedure. And another big field is an interfacial plane blocks, especially the newer blocks like erector plane block and rhomboids block and all. And for refractures, whether it's a conservative for the patient recovery from, especially patient may have a lung contusion and other lung problems. We have to give an excellent chest physiotherapy and all. It's very useful. And more than adding to that is current day the surgeons they are operating. Previously we are all using the conservative line for the rib fractures, and last week we done a 3 to 9 level posterior rib and 3 level lateral rib fracture. We done a last week complete fixation, and nowadays the trend is that more of a fixing because the morbidity is less and the recovery is fast. So they are especially very useful is an erector spinal plane block and put a catheter there, and excellent post-operative analgesia. Most of the only pain patient might have is a chest tube that is hitting the parietal pleura. That maybe causing some irritation. We need some other analgesic for the visceral pain, another support. Otherwise, absolutely no need for any opioid or another things. Most of the time, the refractures and all other thing, we always put an this thing, analgesic, pediatric or other bupivacaine, buprenorphine patches on the fentanyl patches, all we keep. Nowadays, we are not at all giving any serum and opioids, just given a spinal block catheter and put a catheter, and we are continuous, not a continuous, programmed intermittent bolus. That is best for that. Another one caution also I want to mention is that the plenty of interfacial plane blocks, large volume are using in the postoperative period, so you should be very cautious about the last local anesthetic toxicity there in a remote location. So and one more point is just to add is that analgesic, all the interfacial plane blocks are analgesic blocks. We know that, but it's very useful in some of the high risk patients. Patient is having a terminal patients, all other patients. We can do definitive surgeries like umbilical hernia, infected umbilical hernia, or infected thyroid, or whatever may be any level. We have a patient is having on terminal cancer, on a severe ascites and all. You want to give us some procedures, you can do it as an anesthetic agent also, anesthetic block also, without ketodex or pseudo analgesia, or sometimes we don't need anything also. So the facial planes are blocks and honorable blocks are coming out in a bigger way. Anyway, Bala is here. Okay, Bala, please come and down.
Yeah, thank you. Thank you so much to the entire leadership of ISA Kerala State for starting this Connect. I think this connect will connect several minds, thoughts, and which will transform into actions when we see the patient. And I think it is extremely crucial that every single anesthesiologist practicing anesthesia today have to adopt regional technique as a part of their armamentarium as a part of the multimodal analgesia. And it's now beyond doubt that not only it produces excellent quality of pain relief, but also if it is given prior to the surgery, decreases the intraoperative requirement of anesthetic agents, excellent recovery, better cognition, and early ambulation. And also, more importantly, the pro-inflammatory cytokines that are released are supposed to be less. And I think the more and more we do major procedures and critically ill patients, regional analgesia forms such an important component. And one more important thing, whenever we use regional analgesia, it's always a belief that it is sufficient enough, but it is not so. We should not forget to give multimodal analgesia. So it should be a combination of regional, intravenous paracetamol, if no contraindicated non-steroidal anti-inflammatory drugs, and opioids to an extent when it is a visceral pain is involved. So multimodal is the answer. Regional forms an inherent component which decreases the requirement of other analgesic agents. But we need to use all of them together to produce long-term outcome which are good. And the development of chronic pain syndromes are also very less. So I'm very happy that ISA Kerala State Chapter started this. And one of the first sessions have been dedicated to regional anesthesia and analgesia. Thank you for the opportunity. And I'm sure that this connect will make waves in percolating the knowledge with members of the Kerala State branch. Thank you, Binil, and thank you, Dr. Vijesh, for initiating this endeavor.
Thank you, Bala.
Thank you, Dr. Sajish. I'm so happy that you were giving such excellent insights into regional, and I'm very sure that together we will make every single patient in our country receive a regional block.
Both our speakers are ready to take the questions, but we don't have questions in the chat box. So moderators, Dr. Rajesh and Dr. Sajish can make their comments and ask their questions.
So, as Dr. Sajish said, interfacial plain blocks or any regional anesthesia procedure is part and parcel of our multimodal anesthesia plan. So, it is imperative that we anesthesiologists and the our junior colleagues should master the skill of regional anesthesia, and they should have a thought process wherever possible, the application of regional anesthesia along with analgesia, which will add to the quality of our work. I think that's what our president, Professor Dr. Balavenkat, also has highlighted. Thank you, sir.
Yeah, thank you, Rajesh, sir. Thank you.
Any closing comments, sir, from the Bala sir, Bala sir?
Yeah, again, it's an excellent beginning for this series of programs of ISA Kerala. Aptly started from our national president and the secretary of WFSA. So thanks for inviting me also to this program. And the second topic which I presented, just I want to convey that if there is a scope for uploading probably one or two material on the ISA Kerala website related to this series, I can give a PDF or Excel sheet, because I was speaking to Dr. Sanish also. For example, a journal club presentation about randomized controlled trials, what a PG or any staff can just filter the material and enter into that Excel sheet. So if people are able to just enter the different columns and the rows of this Excel sheet, okay, they can pick it up and present in their respective departments. So have that Excel sheet. You can put it up there, or if any of the participants are interested to know something about how it is done, you can share my email ID with them. So that's one thing. Because the topic chosen that's the reason it's very good. Majority of the medical colleges journal club is taken up. When it is taken up, the quality of the discussion is very poor because the basic framework of how that should be done has not been understood by many of them. It's purely out of lack of information that the journal clubs are not being taken up seriously. So if they are taken up seriously, definitely it is extremely educative for the PG students and for us as the senior consultants or the moderators or as faculty. So we can also exchange between the faculty also during the program. So that's the importance. I just wanted to convey to the team ISA now, ISA Kerala. Please consider, if required, I will transfer that also to you.
Thank you, sir. Thank you very much. Now I welcome Dr. Sanish PJ to announce the quiz results. Most awaiting part.
Thank you very much, Dr. Binil. Has been very interesting start to ISA Kerala Kahoot quiz this time. So next week onwards, we'll try to identify the winners and announce the result with their name straight, because this time some people did not write their mobile number. So maybe it's about familiarity with the pattern and all. So let's go into the result announcement. Yes, we have stopped at the answers for the 5th question. Who is the winner? November 1st ISA Kerala Kahoot quiz. The podium is there. We have the 3rd prize winner, the 2nd prize winner, and who is the 1st prize winner? Yes, waiting. Oh, nay. Okay. Now the problem is because the mobile number is not available. So I request the winners, all 3 winners, to contact us at the email address provided, ISA Kerala chapter@gmail.com. We'll definitely proceed with dispersing the cash prize. Is 1,001 rupees for the 1st prize winner. Congratulations, Sneh. I don't know the remaining part of the name. You can probably text it on the chat so I can display it for all your friends and colleagues. Okay, do contact us. I think GK is Kavita, right? So, and SRUT is Shruti, I believe. So anyway, yeah, you all send us maybe a screenshot of this along with your full name, mobile number. So we'll contact you back and give you the cash prize for the 1st winner and e-certificate of appreciation from ISA Kerala State Chapter for the top 3 winners. Congratulations. Next week, we'll continue with another set of questions. We're waiting new winners every time. So it's a chance to compete with the knowledge among your peers, even with your seniors, because there is no distinction between postgraduates or consultants at this platform. Only knowledge matters. Back to you, Dr. Binil and Dr. Bijish for the.
I think the first prize goes to SNEH, that is Sneha.
Okay.
So must be Dr. Sneha Lucas from Jubilee Mission Medical College. Let's see. Okay. Let's see who is it. We'll check it.
Mobile number was not there. We are not sure. Yeah. That's fine. Okay, next time I request all the participants to put the first 4 letters alphabets plus mobile number so that we can immediately identify. So by the time we announce the result, we can tell the exact name also.
Yeah, thank you, Dr. Sanish. And now I welcome Dr. Vijish, our Honorary Secretary, Kerala State Chapter, for expressing the vote of thanks. Over to you.
Yeah. Thank you, Dr. Binil. It was a wonderful session, 2 sessions that we had here. So I would like to take this opportunity to thank Dr. Bala Venkat sir for inaugurating and giving the first lecture today, and also to Dr. Sukhminder Singh Bajwa for being the guest of honor. I'd also like to thank Balabhaskar sir for giving us insights into the journal club, how to present the journal club. We'd also like to thank our patrons, Dr. BRK sir and Dr. Venkatagiri, for giving the felicitations and being part of this inaugural session. Also would like to thank our president, Dr. Binil Isaac Matthew, for giving us this opportunity, to giving us this platform, and also to our academic coordinator, Dr. Sanish PJ, for organizing this event in such a wonderful manner, and especially for that wonderful quiz that he has conducted. Also to our webinar coordinators, Dr. Rajesh and Dr. Sajish, for coordinating this event in such a beautiful manner. And also to all the participants, you are the backbone of this program. So kindly spread the news of Anesthesia Connect to your colleagues so that more people can be benefited by attending these sessions every Saturday. Thank you very much.
Thank you, sir. And now Dr. Venkatagiri has joined. So, any last word from sir before closing the event? You are muted. Dr. Sanish, please unmute, sir. Sir, can't hear you. You are muted.
Giri sir, please unmute from your side.
Oh, from his side, you just.
Yeah.
Yeah, now you are unmuted.
Thank
sir,
you,
please.
Vinil. Thank you. It was an excellent program, and really happy that you have restarted. Remember that what you have done that during your secretaryship, we had excellent academic program. Now you, as the president, again you restarted it, and hope it will be overtaking your secretary's program, and it will be. And we have very good team now. That time I think you were alone, and I was somewhere between you and getting this connection and all. Now you have a good academic team with Rajesh, Binil, then Vijesh, Rajesh, and Stanish. All are excellent team, and really we can make a wonderful program, and it will have more popularity than our earlier program. Great going, good. Really enjoyed the program too. We'll have excellent program throughout the year.
Thank you, sir. Thank you very much. So, with all your permission, shall we close the meeting today?
Thank you.
Thank
Good
you.
night.
Good night. Dr. Sanish, please.